Welcome to the JBI podcast. My name is Sarah Abdolcader, a clinical practice consultant for professional nursing practice at Kaiser Permanente, Northern California. I am a master's prepared nurse with 17 and a half years experience in acute care adults and labor and delivery. Infinite gratitude to Dr. Vanessa Martinez for providing an opportunity to review and give insights on the manuscript on improving the quality of medication administration practices in a tertiary Australian hospital, a best practice implementation project by Lucy Lynn Lizarrando et al. In 1999, according to the Institute of Medicine, now National Academy of Medicine report, To Err is Human, Building a Safer Health System, estimated that 44,000 and 98,000 Americans die each year from preventable medical errors. It highlighted that medication errors as a significant contributor to preventable harm and death in healthcare, and most common types were during the administration of medication phase. It's understandable why most healthcare systems are inclined towards developing improved implementation strategies for increased patient outcomes. There is a surmounting amount of evidence to indicate that the entire medication process in the healthcare system has a multitude of points where they might fail, from prescribing, right, as indicated in the article, all the way to administration and looking at the potential responses for the patient. The manuscript's main objective focuses on improving medication administration practices within a tertiary hospital in Australia. The topic is highly relevant to patient safety, as medication administration errors are a significant concern in healthcare, leading to adverse drug events and preventable harm. The project follows a best practice implementation framework, which adds practical value to addressing these errors in the clinical setting. One thing that I was really impressed was the engagement of a lot of different key stakeholders, which is extremely imperative to the success. A common theme that I noticed is a just culture presence, where they improved patient safety through open communication, learning, and shared accountability from different levels of leadership and staff, and also different multidisciplinary teams. The staff leads were valued for their input in their microsystems and unit, which overall contributed to the success of the implementation due to establishing buy-in from inception. There are some potential sources of bias in this manuscript. One is the selection bias. This study was conducted in a single tertiary hospital, which limits the generalizability of the findings. 2, observer bias, the use of direct observation to monitor administration of medication that can cause the staff to alter their behavior because they are aware they're being observed. So they might improve the way that they are, giving patient medication, adhering to policies, which is also known as the Hawthorne effect. 3, reporting bias. There is a possibility that only positive outcomes were highlighted, with less emphasis on challenges or failures encountered during the implementation process. The project follows the Joanna Briggs Institute's practical application of clinical evidence system, PACES, and getting research into practice, GRIP, frameworks. While the use of these frameworks is a strength, one limitation is the lack of a control group or comparison with other hospitals that did not implement the intervention. The absence makes it difficult to attribute improvements solely to the intervention as external factors. For example, staffing changes, hospital policies could have influenced the outcomes. The study also relies on a relatively short follow-up period, which limits its ability to assess the long-term sustainability of improvements. This study offers valuable insights into improving medication administration practices through the implementation of evidence-based guidelines. However, several limitations, including potential biases, lack of a control group, and a short follow-up duration, reduces the strengths of the conclusions. Future studies would benefit from a longer-term follow-up period, more detailed in error reporting, and a multi-site design to increase the generalizability of the findings. In closing, I want to express my immense gratitude to JBI and to the manuscript's authors, especially Lucy Lynn, for the privilege to share my thoughts. Thank you to them and the co-authors for the study and efforts to improve patient safety and outcomes. Thank you.